Hi there, and welcome. My name is Jeff Bell, and on behalf of the entire Deconstructing Stigma team, I'd like to thank you for joining us today. Our focus for this session, effective treatment approaches for OCD in adults. The good news about obsessive compulsive disorder is that it is highly treatable, but that treatment needs to be the right one. So, our goal today is to explore the most effective approaches for addressing OCD in adults, and our guest knows a whole lot about this topic. Dr. Jeff Szymanski is a clinical psychologist and founder of Getting to the Next Level Consulting. He has over 25 years of experience in mental health as a clinician, a supervisor, a trainer, and an administrator. He served as the executive director of the International OCD Foundation for 15 years, following his role as the director of the psychological services at McLean's OCD Institute. Jeff, always a treat to chat with you.
Great to see you, Jeff.
Well, as you gently pointed out to me before our session, I have a rather ambitious agenda for the next hour, and that's because I have so many questions for you. So let's dive right in. Let's clarify what we are and are not talking about when it comes to clinical OCD. Perhaps you can start with the OCD cycle, as it's called, and its components.
Yeah, so the important piece of this, I think, is to remember that the way the average person uses obsession is not what we're talking about. I'm obsessed with my favorite baseball team. I'm obsessed with this color blue. I'm obsessed with this sweater. That's not what we're talking about with obsessions in the context of OCD, right? So an obsession in the context of OCD is I'm having this thought I don't like. It doesn't feel like me. Why is it here? This is distressing. This is anxiety provoking. This is upsetting. Compulsive. I'm compulsive about cleaning my closet. I'm compulsive about arranging my hangers. That's not what we're talking about when we're talking about compulsive in the context of OCD. We're talking about repetitive behaviors, external or internal, that are done in response to, I'm having these thoughts and images that I don't want to have that are making me anxious. And now I'm going to do these repetitive behaviors to quiet the obsession, to get rid of the obsession, to quiet the anxiety. Now, the OCD cycle is these compulsive behaviors that you're doing are having an unintended effect. And that unintended effect is that your mind is kind of moving through and it's showing you, hey, we might be in danger somehow. And you go, oh my goodness, we might be in danger. I better do something about it. So you do the compulsive behaviors or you leave the room, you do some avoidant behaviors. So that part of your brain that's trying to protect you, you've now just said, when we are in a similar situation in the future, give me that signal. Yep, we're in danger. Look at that calamity that I prevented. So then you end up in this kind of closed loop of I get distressed, I do things to make the distress go away, but the distress keeps coming back. We're not solving the problem. Compulsive behaviors don't solve the problem. Now, the last piece of this that's really important is that this cycle, the struggle that you get caught in, is so problematic that it's time consuming. You're getting to work late. You might have had to drop out of school. You're arguing with family members. So it's also interfering with your ability to live your life the way that you want to. So I would say the D in OCD means something. It means disorder. So it can't be like I'm having these weird thoughts or I like to organize things, right? It has to be interfering with your ability to live your life the way that you want to.
Talk about some of the manifestations of OCD. It can look like a lot of different things.
It can look like a lot of different things, but there are some common themes that you see. And so one of them, the most common one that people know about is contamination. Um, so again, there's two parts of OCD. There's the obsession and then there's the compulsion. Well, I can have a obsession that shows up that says I'm contaminated, and it could show up as I'm going to get sick, or I'm going to get someone else sick, or I'm going to get so sick I'm going to end up in the hospital, or I'm going to get sick and die. And then I'm going to engage in compulsive behavior, but it could be hand washing, it could be repeating, it could be counting, it could be saying a good word, it could be tracking my environment to see what is contaminated or not. So contamination is one. I'm acting irresponsible or I'm going to cause harm inadvertently. So people talk about hit and run OCD. I wasn't careful enough Driving my car, I hit a bump. Was that something, right? So now I'm going back and I'm checking to make sure that that's okay. OCD might invade your faith practice, and we call this scrupulosity. You start to question your relationship with God, or you begin to practice your faith-based practice differently than other people in your faith community. You might have, again, unwanted sexual thoughts or sexual ideas or violent images, and you're like, that is the worst thing I could possibly think of. And so now you're engaged in all of these behaviors that might be repeating or counting or praying, seeking reassurance from others. Am I okay? Am I not a bad person? I'm having these crazy thoughts, right? But again, you stay in that loop as these obsessions show up and you're like, what's going on? You do things inadvertently that keeps the cycle going.
So, despite the fact that these might look very different, these different manifestations, that OCD cycle at its core that you described is playing out essentially the same for all of these different manifestations.
Exactly. So again, we're looking at this mechanism. Your brain is scanning the environment, and a part of your brain called the amygdala goes, hey guys, we've been here before. I think this might be problematic, right? So we start to scan our environment. We start to think about, okay, am I in danger? Is this bad? What could happen? What might happen? What's possible? And we get in that spiral, right? And then we go, okay, I'm convinced that we're in trouble. So we have to do something to prevent that bad thing from happening. And again, as I mentioned, that's what keeps you in the cycle. The behavior reinforces your amygdala trying to help you out. But the problem is sometimes your brain is giving you, it's a maybe. It feels like a true, but it's actually a maybe. Like, guys, check this out. So sometimes we get a false alarm. So essentially, the treatments are aimed at, let's recognize this for what it is. This is a false alarm. And instead of doing your behaviors, we're going to have you just sit and let your brain understand that this is a false alarm. The reason people end up in ineffective treatment is that we want to talk people out of their anxiety. That isn't going to happen to you. If you tap 3 times or don't tap 3 times, your mother isn't going to die. Your amygdala doesn't understand English. You can't talk to your amygdala. You have to show it. You have to behave, right? And so when you go to a traditionally trained therapist for OCD, you don't get better because you don't talk yourself out of anxiety. You have to show your brain these things aren't what I thought. We don't have to protect ourselves. We don't have to do these behaviors. We're going to find out what really happens. And that's when that signal then starts to get quieter and quieter.
What do we know about the prevalence of OCD these days?
The numbers are kind of shift a little bit. So there's 2 numbers that you look at. There's how many people currently have it, and that's like 1 to 2%. So they think like maybe 3 to 4 million at any point in this country have OCD. And then there's lifetime prevalence, and that's more like 2 or 3%. So the estimates are more like 6 to 8 million. So it's pretty prevalent. If you think about, it's anywhere from 1 in 40 to a 1 in 100. Again, these things are ranges. But you're like, if I'm in a mall, if I go to my high school, if I start to think about those numbers, I am not alone with OCD. There's a lot of people that are walking around with OCD and we just don't know about it. We don't see it.
And real quickly, because this is another entire seminar, but what do we know about causes of OCD?
Most of psychiatric and psychological conditions we think are multiply determined. There are some that are more heavily biologically loaded, like schizophrenia and bipolar disorder. And then there are those like OCD that's maybe somewhere in the middle. So when they do neurobiological studies, there's a brain circuit that seems to be overactive that's going on more for people with OCD than people without OCD. We see a genetic transmission. If a parent has OCD, you're more likely, it isn't, you're going to, but you're more likely on average to get OCD. You don't inherit OCD in the way that your parent has it. You inherit that circuit, is what people are starting to understand. And then it's again the degree to which you have an anxious parent who's like, oh my God, everything's dangerous. Let me protect you. It's the degree to which you've, figured out on your own that doesn't seem reasonable. I'm going to approach that. I'm going to push back on that, or I'm going to give into it. Right. And then, we have hormones. So you see this uptick of OCD showing up around puberty. You see it happen around big stressors. So you see another uptick late adolescence, early adulthood when people are leaving home and going to work or going to the military or going to college. So stress related, hormone related, neurobiology, a little bit of all this, a little bit of learning, a little bit of what are parents doing, a little bit of like how am I figuring out how to navigate my world?
So, Jeff, before we dive into treatment, which is going to be the crux of our conversation here, let's talk a little bit about official clinical OCD diagnostics and what's involved there. What does the DSM, for example, say about OCD and how it's defined?
So we need to have the presence of obsessions, which we've talked about, unwanted, intrusive thoughts or images, impulses, urges that cause distress. They might evoke guilt. They might evoke disgust, anxiety. And then the other component is there has to be some sort of compulsive behavior. Now, the compulsive behavior can be washing hands and checking. It can be internal, where I'm mentally reviewing, or I'm suppressing, or I'm trying to figure it out, or I'm thinking of a good word, right? So we have to have those two. And then again, we have to have this impairment in functioning, right? So the symptoms themselves should take an hour or more each day. And the impairment in functioning needs to be notable and significant, right? Where, again, I'm not able to take care of myself the way that I want to. I'm not able to get to work. I'm not able to engage in my social relationships. So when we do these assessments, it's not like going and getting a blood test, right? So you're going to come in and talk with a therapist, and they might use some like structured assessment tools. They might have you fill some things out. Some are scored, and they're like, the most common one is the Yale Obsessive Compulsive Y box, the Yale Brown Obsessive Compulsive Scale, because it was developed at Yale University and Brown University. That's where that name comes from. So you fill this out and it gives you a severity score. And there are other kinds of assessments that you can do. But at the end of the day, it's really a conversation you're having with the therapist who is knowledgeable about OCD, that are like, those are obsessions. Yep, those are compulsions. Oh my goodness, you're not living your life the way that you want to. This looks like OCD.
So, Jeff, in terms of official diagnosis, I think there's some confusion. I imagine some folks who are watching might even still be confused about changes in the DSM regarding OCD versus anxiety disorders. What should we know about that distinction?
So the utility of a diagnosis, let's start in medicine first, right? If you're having a stomach problem, it's important to know whether that's your stomach, whether that's your GI tract, whether it's your pancreas, is it your gallbladder, is it a previous trauma, right? So we need to diagnose, because our diagnosis is going to send us to different parts of the body to treat it. So there's a variation of that in psychological disorders and diagnoses, where we're like, on average, these people are doing the same thing. They show up the same way. They're having the same experience. So we're going to bucket them together. And they share enough common characteristics that we hold them together. And then when they look similar but different enough from this other group. So with OCD, there's lots of anxiety. There's lots of repeated behaviors. With a phobia, there's anxiety. There might be a lot of checking. With OCD, there's a lot of avoidant behaviors. With simple phobia, animal phobia, there's avoidant behaviors, right? So they overlap, but then they diverge in really important ways. OCD has certain themes. It might be more impairing of functioning. A simple phobia like a snake, just don't hang out with snakes. You may not have to get treatment for snake phobia. So in 2013, OCD was in the same, so they do these individual diagnostic buckets, and then they do what they call chapters. And so there's an anxiety chapter. So it's a simple phobia and social anxiety and PTSD, and OCD was in there. And when they started to do more research and we learned more and working more with people with OCD, we're like, actually, there's enough differences that we need to pull this out. So what are the differences? Again, the themes are specific to OCD, about unwanted thoughts. It's about low probability things happening. So in generalized anxiety disorder, for example, I'm worried I might lose my job. With OCD, if it's I don't tap 3 times, my mother's going to die. So we see the difference, even though anxiety is present for both of them. The other difference is that as we started to understand OCD and listen to what people were talking about, it wasn't just anxiety. A lot of people were talking about guilt. A lot of people were talking about disgust. And so there's other emotion states that are prominent. For some people, they don't experience anxiety. They have OCD, they don't experience anxiety at all. They just experience guilt or they experience disgust. So we're like, oh, that's different. And then they looked at some of the neurobiology and all the anxiety disorders, when they're getting lit up, they get lit up in the same part of the brain. OCD is, again, a little bit different. So they said there's enough differences that we want to separate these out. That said, on average, the treatment still primarily looks the same way. Your amygdala is saying this is dangerous, and we're like, I don't know. Let's change our behavior and find out what's actually dangerous and what's not dangerous. So treatment for OCD and anxiety disorder still looks primarily the same.
We sometimes hear the term OCD related disorders. What are we getting at with those?
So OCD related disorders are historically disorders, again, that share overlaps. So the related disorders are hoarding disorder, body dysmorphic disorder, trichotillomania, which is skin pulling or hair pulling, and then skin picking, which is skin picking disorder. So the argument was that they look enough like OCD. And in fact, hoarding was considered part of OCD up until 2013, and then came out as its own disorder. The treatment actually looks different. The treatment for skin picking and trichotillomania looks different, right? So saying a diagnosis gives you a different treatment plan. So you don't actually do a lot of exposure therapy-based stuff with someone with hoarding disorder or skin picking or hair pulling. You do some, but again, it's a degree to which.
And we sometimes hear the term PANS or PANDAS. Again, without getting us off into the weeds, can you define what they are and what we should know about them?
So it is when they first identified this was Sue Sweeto at NIMH, and she was working with kids, and she started to notice that OCD symptoms started to show up quite quickly in a subgroup of kids. And then she was noticing this juxtaposition of they had had a strep infection just prior. And that observation kind of built over time where they started to recognize there are the progression of OCD for most kids, it's gradual. It's that cycle builds over time. But with PANS and PANDAS, it's like the kid turned overnight. And what they think is happening is that they get an infection, the body attempts to fight the infection, but like an autoimmune disorder, it's creating antibodies that create an inflammation in the brain. And that's why you get this like overnight experience of rapid onset severe OCD. So again, different enough that we're going to call it a different bucket. The other biological based OCD that I think is important to talk about is perinatal OCD. And so this happens for people, women that get pregnant or postpartum, where they begin to get worried about the health of the baby, the safety of the baby. They're doing something bad to the baby, right? And we know typical mother worries. You're a dad. You had all those same, like, is my kid
Sure.
okay? This is much bigger. This is, again, lots of ruminations, lots of checking behavior, lots of dysfunction where sometimes the mother can't take care of their infant. The other notable thing about this is that this can happen to the father also, where they essentially get perinatal OCD, where they become overly preoccupied with and develop lots of compulsions and reassurance seeking around their infant pre and post pregnancy.
Let's move into treatment. There's so much to talk about on this front, obviously. Let me start with the big picture question. How treatable is OCD? Any stats or perspective you can give us?
So typical exposure-based outcomes are if you go in and you participate with a effectively trained therapist, and you notice there's lots of caveats to what I'm saying. On average, we see a 60% reduction of symptoms. There's lots of ranges of that, right? It depends on the skill of the therapist. It depends on the client's willingness to follow the exposure exercises, right? The analogy is think of someone who's afraid of snakes or of a dog. Like our common sense is, how would you get your friend over a snake phobia or a dog phobia? You got to hang out with snakes and dogs. So that's essentially the treatment, is that we make you anxious. Who wants that? You're like, I'm already anxious. Why are you making me anxious? Well, we're making you anxious to play out the false alarm. And the only way for the false alarm to get identified as a false alarm is to let it play out, to trigger it. That's the exposure. And then we're not going to do anything to protect ourselves. We're going to prevent the response of compulsive behavior. We're not going to reinforce our amygdala. So again, most treatments are exposure based, with this understanding that we can't have a direct conversation with our amygdala. We have to behave through our anxiety. We can't talk ourselves out of our anxiety.
I will circle back to ERP to be sure, because there's much more to be said about that as well. I wanted to define, or ask you to define, some key terms here that we hear a lot in this sphere. Evidence-based approaches. What are we getting at with that term?
So evidence-based approaches, if let's move into physical medicine for a minute, right? So you have problems with your kidneys. Do you want them like injecting you with blue dye? Do you want them giving you aspirin? Or do you want them to go, hey, we've done a bunch of research. We've worked with patients that have the same kind of thing with their kidney. And when we do this intervention, we give you this injection, your kidney starts to do better. And we've done this with 10, 100,000, 10,000 people. So I'm going to go in with my kidney problem and I'm going to be like, give me that treatment that you've tried this treatment on 10,000 people that shows that it works and makes my kidney better. That's evidence-based care. So when we're working with people with OCD, we go, let's do exposure therapy. Let's do talk therapy. Let's do equine assisted therapy. Let's do, right? So there's research literally where we have clients go through research projects, they get different kinds of treatment, and then we look at who does better. And then as we gather evidence, we feel more confident that this is the treatment that when you show up in my office, I'm going to have gotten trained in that so that I'm giving you the best available care out there. But there's degrees of evidence, and exposure therapy is that kind of therapy that's been around the longest, has the most research behind it. So on average, people are like, let's start there. The caveat to that is you're like, I ain't going to do anything that makes me anxious. And so then it's the question of, we should start with exposure therapy, but I get it. And maybe we need to pivot and try something else before we get you there.
At the risk of getting into the whole alphabet soup with OCD, we've got ERP, we've got CBT. Let's pause real briefly to talk about CBT, because that is an umbrella term that can be kind of confusing as well. Cognitive behavioral therapy. Can you break down the components for us?
So cognitive behavior therapy, what holds that whole tradition together is that they believe that any treatment you provide a client should have some research, some evidence behind it. And so we need to be able to measure and see, a person came in at this level of functioning, this symptomatic, and we did this intervention and they got much better. So that's what holds the whole CBT community together. As we break it down, it's your thoughts, your cognitions might be affected. They might be part of the issue, right? If I find out I have a problem with my kidney, and now I'm thinking about my kidney and what might happen, and now I'm going to die of kidney disease, and now I'm going to be on dialysis. Oh my God, now I'm anxious, right? So in CBT, your thought process, your cognitions might be part of what we target. Your behaviors, every time I get anxious, I avoid that thing that makes me anxious. Now I'm avoiding everything. We have to change and target your behavior, right? But there's lots of ways of doing that. We can make you more skillful. We can do exposure therapy. We can look at what the relationship is, the way you respond to your internal world. These thoughts show up, and every time you try and push them away, that isn't working. Do we have another way of dealing with and responding to those thoughts? So that's what holds all those pieces together.
ERP, exposure and response prevention. You've touched on this. Walk us through the whole process, and maybe some of the brain science behind it as well, which is really truly fascinating.
Yeah. So again, we were talking earlier about some of the neurobiology studies, and there's this circuit that's happening, and they took people and they gave them medication, and then they were on medication for a while, and they took pictures, and they're like, oh, the medication actually slowed that circuit down, and that correlated with a reduction in their symptoms. But what's interesting is if you do exposure and response prevention therapy, again, we're going to take those things that trigger your OCD symptoms, trigger your obsessions. We're deliberately going to go into situations, have you experience that purposefully. And then we're going to, again, the response prevention means we're not going to avoid, we're not going to leave, we're not going to do anything to keep ourselves safe. In doing that, we are, again, talking the language of that circuit. The circuit slows down. The amygdala says, oh, what I thought was an issue, my bad. That wasn't what I thought it was. Thanks for checking that out. And again, you see these pre-post outcomes where exposure therapy literally can slow that circuit down. We can change how our brain works by changing our behavior. But the key to it is that you really have to do the response prevention. You really have to say to your amygdala, like, this isn't what we think it is. Please stop giving me the signal. It takes repetition. It takes some time. It isn't something, there's no insight-oriented cure. We don't go in and we go, oh, I should just not think these thoughts. That's not how it works. There's lots of practice. So it involves participation. It involves you doing things. It involves you doing things in session, not just talking about it. It involves you doing things between sessions. So it's a very intensive, it's kind of like having a personal trainer, right? You're going to go and you're going to work out a couple times a week. You should probably be working out in between. Your therapist is your personal trainer. They're just a coach, but you have to do multiple repetitions if you want to build your muscle.
Yeah, it really is paradoxical. It's kind of like this whole concept that the only way to navigate uncertainty or anxiety is to actually embrace it. I mean, that's what we're doing with ERP. It's not easy. Can you talk about some of the attrition challenges with ERP?
So, well, let me mix these two topics because it's really interesting that we all, whether we have OCD or not, we all know, in fact, that anxiety can show up. And if we stick with that task, it transforms. So I'll give you an example. Do you remember going to elementary school on the first day? Do you remember going to high school on the first day? Do you remember your first day on the job? I bet in any of those scenarios, there was a certain amount of anxiety. If you went back home, you didn't finish school. You know that experientially. You had anxiety, you moved through it, and your understanding of the world and your anxiety settled down because you embraced anxiety as like, oh, there's uncertainty here. I'm not sure what's going to happen. So I should be a little on guard. That's all anxiety is. It's like, be on guard. But we all have the wisdom, we all have experiential knowledge of we move through the world with difficult feelings. And if we do that, we come out the other end and the feelings are transformed. So that's the same process that's happening in exposure response prevention therapy. It's not new, right? However, people are almost traumatized. Some people would say they are traumatized by their experience of their anxiety. So it's common for someone to come in and say, I have terrible anxiety, I have terrible OCD. My goal is to have no thoughts and no anxiety, right? Which is problematic, right? Because anxiety keeps us from getting hit by cars.
Yeah, it's natural.
It's natural. It's our warning signal. We don't want to get rid of our warning signal. But so there is a desperation of like, make this go away, which is the antithesis of the spirit of exposure therapy that gets you better, which is I'm going to be willing and curious and open to what's going to happen. And some people are just like, I'm not going to take that risk. I have to tap 3 times to keep my mother alive. I'm not risking killing my mother. Like, get lost. So there are some problems with attrition rates. There are some problems with, again, as you explained it, I don't like it, or I'm going to start it, this isn't for me, or I'm going to start it and I'm just going to power through. So there's difficulties with the treatment. And then there's difficulties with the quality of the training of the therapist, right? So ERP looks deceptively simple. Oh, you just find out what makes them anxious, you make them anxious and help them not do the compulsive behavior. So it looks deceptively easy. So there's some people out there like, I'm doing exposure response prevention. You're like, not really. So it's important to, as you're looking for treatment, like how much training do they have? What's their understanding of it? Are they able to explain it like I'm explaining it, about how this works?
There are different types of exposures that a clinician can use. Imaginal or basically virtual forms of it, physical forms of it. What should we know about those different buckets?
So the best way to do exposure therapy is to find different ways to be in contact with that thing that's making you anxious, right? So for example, I want you to drive your car. I don't want you to be looking in your mirrors. And I want you to be saying out loud, I might have hit someone when I hit that bump, right? So there's the physical being in there. And then there's the mental, we're going to like say the scenario out loud and we're going to put ourselves in touch with that feared thought, that feared outcome. Again, we're trying to light up our amygdala and go, guys, this isn't what you think it is. It's just a bump in the road. We can't convince you of that. So we're really going to drive it home. We're going to drive over a bunch of bumps and we're going to say, maybe I hit someone. So you can also do, so you can say that phrase over and over again. You can, sometimes your therapist will have you, so the way I describe it, it's like, if I don't tap 3 times, my mother's going to die. I don't want to talk about it. And I'm like, okay, well, your mother's not dead, but can we play the scenario out? Like, what would that look like? Let's write a scenario of you don't tap 3 times, and then does your mother start to cough? Does your mother start to get sick? Does your mother get jaundiced? Like, let's play this whole feared scenario out. Again, what we're doing is, in this case, avoidance is the compulsive behavior. It's, I don't want to experience that. So we're like, the more you push that away, the more you get it. So just open up to it, right? And when you open up to it, you find out it's not what it is. But again, those attrition rates, you got people that are like, it ain't worth the risk.
How about hierarchies? I mean, traditionally, they have been sort of a ladder of increasingly difficult challenges for somebody with OCD. Is that still the best approach to tackling an ERP exposure?
So I think, again, the more traditional earlier models of exposure therapy, as we were taught it was supposed to be pretty structured and that we're supposed to interact with the client and we're supposed to come up with exposure exercises. It's really more evolved into a much more collaborative process. And it's like, what are the things that make you anxious? And if you're going to start this therapy, right, the compulsive behaviors you're going to want to refrain from. So, of these things that we've talked about, what could you do? What are you willing to do? What are you willing to tolerate? What are you willing to find out about? And then let's go do it, right? So I don't do so much of a hierarchy as like a menu of options. And when you do those menu of options, you're, again, the values that you're behaving differently in the world, that's always valuable information for your brain, right? There's some research that says actually the more random the presentation of the exposures are, in some cases, the more powerful it is. My theory, because that's how the world works, right? There's something a little artificial about a hierarchy. I get the like, I want to do things that I feel are doable, and I still believe in that. But a little bit of randomness is not a bad idea.
Can I put you on the spot and ask you to give us a hypothetical treatment scenario here and what that might look like with exposures at different levels of anxiety?
So let's use the hit and run person, right? So they come into my office and they say, "Look, um, I am worried that I'm going to hit someone with my car." And I say, "How long has this been going on?" "It's been going on for 2 years." "Okay. How bad was it 2 years ago on a scale of 1 to 10?" It was like a 4 or 5. "Okay. So it's gotten worse. Where is it now?" "It's like a 7 or an 8 or a 9." "Okay. So what happens when you get in the car?" I immediately start having these images of, I've hit someone, the cops are here, I'm being hauled away to jail. So I'm like checking my mirrors. It's taking longer and longer to get out of a parking space. I'm now showing up late for work. Okay. So let's do some education about, like, let's get you familiar with what OCD is, right? You have these unwanted thoughts. You start constructing what if scenarios. You start checking your mirrors. Now you're like If you hit a bump, now you're stopping and going back. You're checking to make sure there's no damage on your car. So we're calling those compulsive behaviors, right? So what we're going to do is we're going to start doing some driving stuff, right? I'm going to put you on your Bluetooth. I used to get in people's cars. I don't do that as much anymore. Now I'm just like, put me on your Bluetooth. Get in the car. Are you having obsessions? Okay, let the obsessions tell me out loud. What are the obsessions, right? I might hit someone. Okay, so let's say out loud, I might hit someone. Maybe I hit someone. Maybe I've already hit someone. Oh, well, that doesn't feel good. Okay, well, our job is to talk to your amygdala. We're going to talk to your amygdala by do one check in your mirror, back out of a parking space. Can you do that? Yep, but I don't know. Did I hit someone? I don't know. Did you hit someone? Why don't you put it in gear and let's drive out of the parking lot? Tell me about your obsessions. Don't look in the mirror. Don't stop and check. At the end of the driving, how did that go? It was pretty anxiety provoking. What did you learn? It wasn't as bad as I thought. What else did you learn? The compulsive behaviors might be making this worse. Okay.
Yeah, and that insight there goes a long, long way in that aha moment that so many people with OCD ultimately have with habituation exercises. Jeff, let's talk a little bit about treatment. I'm sorry, about medication and how it fits into the treatment picture. What are the basics we should know?
So always have to do the caveat, I'm a psychologist and not a prescriber. And the education that we provide is, look, there are medications, typically what are called selective serotonin reuptake inhibitors. So we have a bunch of different kinds of chemicals in our brain. One of them is called serotonin. So these medications, they think change the amount of serotonin in your brain that when you take the medication can slow that circuit down. So you have some symptom reduction when you take some of these medications. There are other kinds of medications, but typically a psychiatrist or your primary care physician will start you with an SSRI if that's your choice, right? So they'll also, with informed consent, talk about like, you have to take these every day. There might be some side effects. If you go off them at some point, the symptoms might come back. They may not. We're not really sure. This medication might not help. It might take 2 or 3 or 4 different medications before we find the one that works, right? You might be on this the rest of your life. You might not be. When someone comes to me, I'm having a conversation with them about how bad is this? The worse it is, the more I'm like, oh, medication might not be a bad idea, right? The less severe it is, do you want to do medication? You don't have to. Exposure therapy is pretty effective, right? So I'm talking with them about severity. Why not use all the tools that you need if you're really struggling? If it's mild to moderate, like let's do the therapy and let's see where that gets you, right? And a lot of people get better from that. Some people do both at the same time. And some people are like, I just want to do medication. I don't want to do any of that scary ERP stuff. Some of those people get better, some don't. Some get better and then they have a resumption of symptoms when they get off the medication. So it's one of those, again, informed choices about what are your different options. But there are starting places. But for me, it's just a conversation with your therapist and prescriber about what are the pros and cons so that you're making an informed decision and what you're willing to put up with.
We've talked about some of the primary approaches to treating OCD. There are also supplementary or adjunct approaches, as I understand that they're called, and one would be ACT. Can you explain what ACT is and why it can help with the process without essentially replacing ERP, for example?
So acceptance and commitment therapy can be used in 2 ways from my perspective. One is that the skills that are taught in that style of therapy can enhance your experience in exposure therapy. And what I mean by that is like I'm touching a doorknob to confront my contamination fears, but I'm looking the other direction and I'm kind of talking to myself. And ACT, we're like, it isn't just that you're touching the doorknob. I want you to notice it. I want you to notice the obsession. I want you to be mindful. I want you to be present. I want you to be willing and open. So there's a lot of skills in acceptance and commitment therapy that some people call it like supercharging your exposure therapy experience. The other way that I use ACT is that it isn't a full-on exposure treatment, though there are exposure elements to it. And so for someone who comes to me and says, I don't want to do exposure therapy, or as you described exposure therapy, I don't want to do that. I use ACT skills and ACT therapy as kind of a treatment readiness, like getting them to the front door of ERP. So I think that's the way people primarily use that treatment. But again, it's more about like, what is your relationship with yourself? So the example I give is I have a lamp in my living room. I don't like the lamp. It's an ugly lamp. So you know what I'm going to do? I'm going to pick up the lamp, I'm going to throw it in the trash, and I'm going to wave to the trash people as they take my lamp away that I never have to see again. So when I have an ugly something that shows up inside, I'm going to be like, I want to pick up this ugly thought. I want to throw it away and I never want to see it again. And unfortunately, our interior rules and our exterior rules don't work the same for whatever reason. My theory is, hey, if this is ugly and terrible and it's so bad that we have to get rid of it, shouldn't we be paying attention to it? So I think there's like two parts of our brain that's like, let's get rid of this. And the other, like, if it's that bad, we should keep an eye on it. And that's when you get this weird pull and push, right? So ACT is really about addressing that issue of when things show up, how do we cultivate an attitude of openness and willingness to lean in before we do structured, really hard exposures?
And just so we touch on all the primary aspects of this supplementary level of treatment as well, DBT, dialectical behavioral therapy, how does it fit into the picture?
So dialectical behavior therapy grew up in a treatment for people that have what's called borderline personality disorder. And essentially people that have this just have a lot of difficulty, lots of problems, lots of difficulties in their life. And kind of the core of it is they have an emotion and it just kind of, it feels like a tornado. So their behavior gets all messed up. They don't know what to do. They don't know how to think. They end up doing things they don't want to do. So the treatment, dialectical behavior therapy, the skills piece, the skills training piece is how do we help people when an emotion shows up? How do we have them in a more skillful way deal with that emotion, talk to that emotion, um, kind of bring it with them in a different way? So for me, if I have, again, someone who's very symptomatic, but they aren't good at managing any of their emotions, I might start with some emotion regulation skills and distress tolerance skills from DBT, get them more solid on the ground before I go and make them more anxious, right? So that's how I use DBT skills. I also use them after the exposure. You need to get back in your life, right? I don't need
Sure.
to do exposure therapy 24/7. That doesn't work that way. So when our exposures are over, get back to your life. And if something else pops up, we don't need to do an exposure. We might use our DBT skills there. So it can be complementary.
Let's talk about co-occurring conditions, which I understand are very common for OCD. What are the most common co-occurring issues that folks with OCD face?
So what you're seeing, and this is a part of the field that's really grown exponentially in the last, I would say maybe 5 years. Because prior to that, like I remember just being at the foundation 15 years ago, and it was like our bandwidth was just like, how do we help adults with OCD? And then it was like, hey, OCD starts with in childhood. We should be helping kids with OCD. And then it was like, hey, and we need to get more people trained in OCD. Now it's like, it isn't just OCD, it's they come in with PTSD and OCD. They come in with a substance use problem in OCD. They come in with an eating disorder in OCD. They come in with a neurodivergent, whether it's ADHD or autism and OCD. So those are the more common ones that you're seeing. And people are now trying to develop like, what do we do? Do we treat the substance use first? Do we treat the OCD first? Do we treat both at the same time? So this is a big conversation that's happening in the field right now.
And where do you see that going, Jeff? I mean, is it going to be more of a team approach to addressing comorbidity, or how do you see that being addressed as we collectively, the field, get better and better at doing this?
I think the historical strategy was someone treats your OCD and someone else treats your eating disorder. I think we're coming to a place of if you want to treat OCD and you are seeing clients that are showing up with comorbidities, you're going to have to get trained in the comorbidities. That we're moving more towards so the example is they come to the OCD Institute for OCD treatment and they start drinking again. We're like, oh, well, your substance abuse is primary. We can't treat your OCD. We're making you worse. Go to rehab. and they go to rehab and they aren't getting to the groups because of their OCD symptoms. So the people at the rehab go, your OCD symptoms are interfering with your ability for us to help you at rehab. Go to the OCD Institute. So that's what was happening. So now it's like, I think we're going to have to like find ways to be more than just an OCD specialist in some cases. And some people do that. Some people really brand themselves as only come to me if you only have OCD, and some are, I also have trauma background. I also have eating disorder background. So you're seeing those kinds of niches and those kinds of specialties popping up increasingly.
Let's talk a little bit about the longer term aspects of OCD treatment. Relapse prevention, for example. What should clinicians know about how that is addressed?
So it's a funny thing because the other theory that has shown up in the body of research that showed up about 15 years ago is called inhibitory learning. And essentially what this means is they said, look, you learned something at 5 years old, you learned something at 15 years old, you learned something at 25 years old. Your 25-year-old self doesn't overwrite your 5-year-old self. You don't unlearn things. And so it's like we have these different buckets of learning that are still hanging around, right? So even if you get a lot better with exposure therapy, you might hit a place after treatment where you're like, oh my goodness, symptoms are coming back. And people call it a relapse or a decompensation or a regression. And I'm like, is it? Or is it just that your old learning showed up? Like that's literally the meaning of inhibitory
Mhm.
learning. All that new learning you have, we want to make it big and we want to make it robust. And when you go into these what used to be problematic situations, your new learning shows up and you go, oh, I don't need to worry about this, right? It inhibits your old learning. But for one reason or another, if we didn't generalize it to enough different situations, or you got sick, or you're under a lot of stress, your old learning might just show up, right? Not a big deal. We go, oh, that's my old learning showing up. So got to do more ERP. Maybe I need some booster sessions. Maybe I got to like double down on my practice of leaning in. But I try to decatastrophize the resumption of symptoms. It seems to be a normal process that happens in any psychiatric disorders.
So, one of my takeaways from your overview of all of this is that it does take a lot of skills to be able to effectively address OCD as a clinician. What is your guidance for people who are perhaps a generalist, for lack of a better term, wanting to get more training, and what would you suggest that they do to get that training?
Yeah, and again, Jeff, you were at a board of director on the board of directors at the International OCD Foundation. We overlapped for many years.
Right.
And there was this sense of like we were the only game in town for a long time. And the good news is there are tons of opportunities, whether it's through the IOCDF, there are tons of really good training groups. There are tons of webinar series training, like my entire current business is on doing trainings and consultations with people who want to either learn the skills or elevate their skills. But there's probably 150, 200 people. I think the best resource is there's a Facebook group called OCD and related disorders specialists. And you get in there, there's 5,000 clinicians in there, and people are talking about trainings and consultations that they're doing, and they do like little consultations between it. But I think that that's an amazing resource for that.
And finally, I want you to ask you to speak to anybody in our audience who is not a clinician, but perhaps somebody dealing with OCD or a loved one of somebody who is, and is a little overwhelmed by all of what we shared in terms of how do you find somebody who can do this? What questions should I ask when screening potential therapists and so forth? What guidance do you have for them?
Yeah, I think that one of the things we tried to do at IOCDF was to develop a resource directory. So in the resource directory, it's therapists, it's specialty clinics, it's residential places. And what we asked people to do was to really describe like, what is your background? What is your training? Right. And so you're looking for the buzzwords of I'm ACT trained or I'm ERP trained, right? And so you're going through that, but Psychology Today does that. NoCD does that. There are a number of different kind of uh, treatment provider databases, but you know, educating yourself about the treatment. There's a ton of books. Again, 15 years ago, there were 10 books. There's thousands of books on OCD. There's great books. There's go and look for stuff about when my family member has OCD. What do I do? When my family member is refusing treatment, when my kid has OCD. There's just go on Amazon. There's a million books. Educate yourself is the most important thing, I think.
And Jeff, when you look back on the 25 plus years that you've been doing OCD treatment, what stands out to you as the evolution of this whole field?
I think it's that, again, that kind of we were the only game in town and exposure response prevention was the only effective treatment. There's a lot of things in the space now, right? There are a lot of organizations, there's a lot of trainers, there's a lot of very well-trained people. There's a lot of participation in the community. There are treatments devoted specifically to just working with family members in a way that there wasn't before. So the number of therapists in the field is exponentially grown. The number of people with OCD that are OCD therapists has exponentially grown. So there's just a lot. There's, we were talking about DBT and acceptance and commitment therapy. There's inference-based CBT. There's, the SPACE program for treating families. There's other things that are coming into the space that give us more alternatives, right? They give us more opportunity to meet clients where they're at, give them things where they're willing to take them. Right before it was like do exposures or I can't help you. I always hated that option, right? And it feels like there's a lot more robustness. There's a lot more people at the table. There's a lot more people participating, both from lived experience and family, but also like the treatment community is gigantic now in a way that it wasn't just 5, 10 years ago.
So I'm looking at the clock. We've come just about an hour here, and we've actually packed a lot into that hour. You are very good at getting to the bottom line of these issues, and I know that we can do additional seminars and additional webinars where we dig down deeper on these topics as well. But Jeff, thanks as always for loaning us your expertise.
Absolutely. Thanks for having me.
Dr. Jeff Szymanski. And to those of you watching, thank you for your interest in our Deconstructing Stigma video series. We hope you'll come back for our future sessions, and we wish you a wonderful day.